From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello and welcome to our listeners around the world. You're listening to JAMA Dermatology Author Interviews. Thanks for joining us. I'm Dr. Adamson, the web editor for JAMA Dermatology and host of this podcast episode. Skin conditions contribute substantially to the global burden of disease and are among the most common reasons people seek healthcare. Yet access to dermatologists remains a persistent challenge. Artificial intelligence-based tools offer one potential way to narrow this gap by helping people access skin health information more easily. However, these algorithms may also cause harm by providing inaccurate information, increasing anxiety among otherwise healthy individuals, and prompting unnecessary healthcare utilization. In a new study published in JAMA Dermatology, authors report findings from a randomized multi-reader, multi-case, survey-based study examining whether everyday consumers benefit from AI assistance when presented with de-identified case vignettes of dermatologic conditions. And you can find a link to this paper in this episode's description. Dr. Rory Sayres is a researcher at Google. He is the first and corresponding author of this new study, and he is here to discuss this work. Welcome to the podcast, Dr. Sayres.
Thanks so much, Adewole. Happy to be here.
So this is the first time I've had a Google researcher on the podcast, so I'm excited. Do you mind telling our audience what type of stuff do you do at Google? Is it AI-related things in dermatology only? Are you agnostic to disease or specialty category? What do you do?
Thanks. Yeah. So I'm a researcher. I describe myself as a human-computer interaction researcher. That's my field, which is part of just the human element of AI systems. So I've been working for the past 10 years on a team called Health AI. We're specific to health and medicine, and we focus on different aspects of health. And the main goal is helping make sure AI is an accurate and trusted source, and it actually works in a system rather than just being an extra screen or something that doesn't actually improve the standard of care. So I do this by working with teams. I sort of embed in these engineering teams that develop AI. We originally started with ophthalmology. So I spent many years working with these models that would work on images of retinas and would predict diseases like diabetic retinopathy. For about 6 years, though, the most strongly represented specialty in what I studied was dermatology. And one thing we noticed when we looked at dermatology was there's a benefit to clinicians, but this is also an area where we thought that lay people might also benefit from, having access to this AI.
And by access to this AI, you mean access to algorithms that can help in diagnosing or suggesting diagnoses of people that have skin conditions.
Yeah, that's exactly right. And one of the things I was studying was how to frame it, because when we're working with clinicians, you mentioned diagnosing, and that is often explicitly the goal. But when consumers are looking for information online, it's not always clear that that's what they're looking for. So in the study, we assessed how well they could name conditions and compared them to what a dermatologist might say. But we also look at things like the next step. What would you do next? Because in interviews, that always comes up as one of the main things you're really thinking about is how urgent is this?
Okay, so it sounds like you and a lot of people are thinking about this question of how do we get patient-facing AI algorithms that are trustworthy for people that have health conditions, and in particular, skin conditions, right? And that's kind of what motivated this study. What I found really interesting about this study is the fact that you used real images from a teledermatology program, I'm assuming it's the one at Stanford, that represented the cases in which you asked participants to use in order to research what that particular diagnosis is. I know I'm sort of partly summarizing the methods of your study, but do you mind starting with describing kind of the algorithms that you used in this study, and then we can talk about how you then recruited participants and what you found, et cetera.
Sure. So the algorithm we used in this study, I would describe it these days as sort of more of a narrow algorithm. We're living in this era where there are all these newer AIs, we sometimes call them transfer-based architectures, that can do a range of tasks. The algorithm in this study was a neural net that was based really specifically for understanding dermatological images. So it wasn't doing all the sorts of things. It was really focused on dermatology. It is similar to other models that we've published other papers on where we developed models like this. It's slightly different, and the details are like not really the focus of this paper. But the main thing is it could take a series of images that would have skin conditions and determine if there was anything that looked like a skin condition and which of 288 possible skin conditions it might be on that. And it would give a list of 3 to 7 possibilities.
And there were actually 2 algorithms in this study. One was older one, and then there was kind of an updated, what you called a Wizard of Oz algorithm. Am I presenting that accurately?
In a way, the Wizard of Oz was interesting. I really like that aspect because it wasn't really a computer algorithm. It was people. So, like in the movie Wizard of Oz, I don't know if you remember, like, Dorothy goes to see this very imposing wizard, and then Toto pulls back the curtain and it's actually just a person pulling the levers. That's kind of the same thing in this study where what people saw was this interface that looked like an AI-based interface. And in one arm of the study, it really was the AI. It was coming from an AI. And the other arm, it was coming from dermatologists. And so those predictions that people saw in that one arm were the actual predictions that were like what that person in that telederm case had. So it was as accurate as possible. So that was interesting to me because it let us isolate how accurate is your model as an important question from a lot of the other questions, like how well do people understand what they're seeing?
All right, so now let's jump into the mechanics of the study. You recruited, I want to say, like 1,000 people almost to this study?
It was 2,500.
Okay, even more, 1,000 per arm you were trying to recruit. So you recruited a lot of people. And how did you recruit these folks?
Well, we worked through different partners. In this case, it was Qualtrics, and they have these panels of people who are US-based and who engage in studies like this. And they're willing to go the extra mile. Like, we classify this as a survey study, but it was a pretty involved, detailed one, because if you're a participant, not only are you seeing these different images, and you're given some details. So like, this might be like a 40-year-old woman who's been experiencing this for 2 weeks, and they have these other conditions. But you get 5 of these cases and you evaluate. And each one, you're given as much time as you need. For some people in the control arm, you just go on the internet or use whatever you'd use as if you were helping this person to study. And then for the other 2 arms, you got this assistance, either from an AI or in the Wizard of Oz, you got it from something that was presented like was an AI, but it was actually from doctors.
So if I were to summarize what you said about the structure, is that you randomly assign people to 3 possible scenarios. One was usual care, which is, here is a teledermatology image. Imagine yourself having this disorder and needing to do research on it, and all you have is the internet. Go. The next bucket is you're presented again with this teledermatology image and you're asked to imagine yourself, but you can now use the assistance of an AI technology, right, for this. And then the third bucket was do the same thing, except we're going to give you this Wizard of Oz scenario where it's actually the answers from a board-certified dermatologist on this specific case. So it is the ground truth. And then you kind of measured in these 3 arms how long it took for folks to do their research and also how accurate they were. Is that a fair representation of the study design?
Yeah, that's right.
So what did you find?
So we found a couple things. One of the things that I would say for me was a larger effect than we expected to see was on accuracy for what is the condition. There's also a little nuance here because we're working with people who are not clinicians. When we run a study like this with clinicians, we assume they can list a differential diagnosis, and so they always are required to say, what is shown here? But for people, they don't always know, and they don't always even feel comfortable guessing. So if you're seeing a picture of a skin concern, you might be able to guess. But first we would ask, like, just do you feel like you might know what this is? And that rate went up quite a bit in both the AI and Wizard of Oz arms compared to our control arm. Then if they said yes, we'd say, okay, type whatever you think, like it can be multiple possibilities, so it doesn't just have to be one. And we take what they wrote and match it against what dermatologists said. And we had to account for things like, mole can be like melanocytic nevus,
Yeah.
So we would map for those sort of inconsistencies, but we would just take that accuracy. And that also went up quite a bit in both arms. Then finally, like I mentioned, we also cared about like next steps. Like what would you do if this was your situation? Would you see a doctor? Would you see it urgently? Would you try and just treat at home? Would you just wait and see if it got worse? And we would compare that to dermatologist assessment. That only went up in the Wizard of Oz arm. It didn't go up in the AI arm, which suggests that the accuracy mattered, that the Wizard of Oz was totally accurate, and that helped people make more accurate next step assessments.
So then what is your take from this study then? If the Wizard of Oz arm seemed to be somewhat superior, or is that not a good framing?
For condition accuracy, it wasn't necessarily much better than an AI prediction, but for next step, it was. So it told me two things. One is just the fact that this goes up means that, tools like this can actually be useful, we think. Like, if it helps you name what you have more accurately, hopefully that will help be a little less concerned that people will be rushing to get to their dermatologist when it's not a concern, right? But actually assessing that is still really hard. Even if you know the names of what you have, there's still a lot of variability in terms of, is this something I need to see a doctor right away? And we know, especially in dermatology, whether you want to see a specialist is a big question because the wait times can be tremendously long and access can be tremendously long. And so the fact that we saw it higher for the Wizard of Oz says, okay, even though these models were performing pretty well on this data set, getting them to be even better would make a meaningful difference to people. Getting them to be better would mean people would make better assessments of what they should do next. And we think that that's one of the most important things we want to make sure AI helps you with, is like figuring out, is this urgent?
And by what should happen next, is the question, should they go see a specialist or not? Or is what next, what specific treatment they should have versus not?
Oh, yeah, that's a great point. And I should clarify, when we're talking about next steps, we're just talking about seeing medical care, right? So like treatment was considered another step that was out of scope for this. We think at some point, for some conditions, you may make that decision, but we were just assessing, would you see a doctor and on like what time scale rather than like, would you treat it?
And in your study, did you measure, I guess, as a proxy, utilization as an outcome?
We weren't able to in this study, like see if they actually went to see the doctor because of this survey-based nature. This is something we've been interested in. And our group has papers of different types with studies where we do want to look at things like that. Like for instance, in ophthalmology, we did look a little bit at when people got assessed for diabetic retinopathy, did they actually go make the appointment to a specialist to actually get treated to sort of help that funnel? We ran another study too, I'll mention, in the dermatology space that I think partners with this well. This was one we published last year in the CHI conference where it was people with their own concerns. So it was at a health fair. It was a smaller qualitative study where we actually had the doctors from Stanford who are co-authors helping. And so people would use the app and then they'd go see a doctor and they would actually consult a little bit for like an informational thing. So you had more of a direct assessment where you had a face-to-face conversation. And that didn't have 2,000 participants like this study in JAMA Dermatology, but it provided sort of this flip side of the coin where you're now having like this deep conversation with the doctor. So you got a better sense of how they viewed their own concerns.
Right. And I guess that's one limitation of this study is that is a reader study and the participants are presumably healthy people and don't have the specific skin conditions that they were asked to research. And perhaps their sense of urgency might be different if they're talking about themselves or a loved one. What is your take on that?
I think it's a really important facet. And we knew that was a limitation here. We have these different study designs that can go for scale. So you want to see lots of people, get strong statistics like in this paper, but then you have that trade-off with getting the deep knowledge, especially when it's your own skin and how you react. One thing we tried to measure in this study was your assessment of how much what you're looking at was like your own. So we did ask questions. Does this case that you're reviewing look like your own skin? Does it seem like something you would take care of or someone you would take care of for? Like I take care of my kids' skin and their skin isn't always the same type of skin as my own. And so one thing we found is that actually was shifted a little bit. And even though it's not in the main study figures, we did a follow-up analysis where when you look at people saying, this skin seems like my own skin, people would engage more. They'd be more likely to guess what the question was because I think they felt that that was closer to their own. So like, we know this is a really important factor in dermatology. And this other study we found also came up of like, the images you show, if they don't seem like yours in terms of skin tone or age
Hmm.
or how severe the condition is,
Hmm.
you might tune out. And that's one of the things we think is important for making sure the information lands. So if you get as accurate as information as possible, you're still not all the way there because you have to make it feel that it's specific to you and that it matches what your experience is.
Yeah, I can imagine if I'm a consumer using the app and, say I have an inflammatory condition like psoriasis, and all the examples that I'm getting are in skin tones that aren't like my own. Maybe it feel a little difficult to figure out whether I'm getting the correct information or not. Were there any discussions within your team around these kind of issues?
Yeah, I mean, it's been an active area, I would say, because one of the things we're trying to do is make sure that our models generalize in general across different populations. And dermatology is an area where historically the balance of images has not been great. Now, there have been other papers. I'm not an author on most of these other papers. We did one version of a paper where we looked at variation in skin tone, found it held up fairly well. But also, there's this effort called SCIN, which was an effort to get more diverse and representative images. My colleague Pooja Rao led this study so we could sort of get a better representative set, which was then open sourced. So you would have more representation of these types of images. So your models see the diversity that's really out there.
So I guess finally, what's next? Where are you taking this research from here?
Well, one of the things we're really thinking about these days is the idea that in addition to the narrow models, like the type we looked at today, we're in a world where there's all of these wide models
Hmm.
and people are turning to these for health questions. So we're spending a lot of time looking at that. My own research, one of the things I focus on a lot now is what does a good conversation look like? So, imagine there's no internet. It's before all of this, but you have something concerning and you have someone you trust and you talk to them. You might show them what your skin looks like, but the conversation won't end there. They'll ask about it. They might ask, how long has it been feeling? They might look at different ways. And you might get something out of that that you wouldn't get from technology today. And we want to understand what those things are. There's a sense that, you decide if you can trust someone you're talking to, and you decide that the information you get is really specific to you. And one of the risks with the new technology is you may not get that, right? You may not trust the technology. You may not get something specific. And so I'm really interested in how do you make sure a conversation is really giving the information specific to the person asking it and their specific conditions.
So you're trying to basically reproduce the clinical interview that you have with patients and like how that dialogue happens, right? Because that's where you extract some of this information that can help you in, establishing trust and also with diagnostic accuracy as well.
I'd say that's part of it, but it's not just clinical interviews because different people have different types of conversations, right? And so some of these are going to be like clinical interviews. Like if you could talk to your dermatologist now, what would it be like?
Hmm.
But for some, maybe it's not at that level of urgency, right? Maybe it's a different type of conversation. So I'd say I'm interested in these different types of conversations, including when you know that this is something really concerning, that you get the same questions you would in a clinical interview.
Well, Rory, it's been fantastic talking to you. And I want to thank you for being on the podcast and sharing your expertise.
It's been really great. Thanks so much for having me.
I'm Dr. Adewole Adamson, and I've been speaking with Dr. Rory Sayres about AI in assisting consumers' accuracy in diagnosing skin disease. You can find a link to the paper in this episode's description. This episode was produced by Daniel Massisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Catch you on the next episode of the JAMA Dermatology Podcast.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.